Well, it's terrific to see everyone on this meeting today. Welcome to our Tuesday, March 5th, 2024 CMDA monthly meeting. I'm Sing Pallet, the president of CMDA. And today, Dr. Chris Horton will be leading our meeting, and you can see the agenda up there on your screen. Chris, go ahead and take it away.
Hi, good afternoon, everyone. Thanks for attending. We're very excited to present our partner updates, and we'll start with Jenny Albertson from CHCA. Good morning. Good afternoon.
Good afternoon. If it's all right, I'd like to share my screen. I have just some slides to share with you all.
Please do.
Got it. Okay. Thank you. Okay. I am going to go ahead and put this in present mode so you can see a little better. I'm going to do a quick little learning with you all to start with, because
Jenny?
this is coming up quite often. Can you see my screen okay?
Nope, I didn't mean to interrupt. That's exactly what I was going to say. I'm still seeing Chris's screen, I think.
How do we?
It says I am screen
control over that, Sing?
If you maybe hover up to the very top of your screen, it should give you the option to stop.
There we go.
Oh, that works. Thank you very much.
I wanted to do a little micro learning session with you all to start with, since I don't have that many announcements. And it's just touching on some regulatory requirements around substance use disorder. Oh, sorry. The issues around substance abuse disorder were updated in the requirements of participation in October of 2022. And I don't think the message permeated through our practice terribly well. So I'm doing a lot of one-off teaching with people that are struggling with this, with residents within their communities. First off, CMS is looking more intensely at this issue, and they have two deficiencies that specifically were updated in October 2022, and those updates included that there is a change in search and seizure. Essentially, a lot of our nursing homes had been practicing being able to look in a resident's wheelchair or walker bag or go into their room and seize drug paraphernalia. That is actually no longer permitted per regulation. And if you were to ask the police, they also would say they are not permitted to even enter a resident's room without a search warrant. So staff have to have consent to search for drug paraphernalia or anything else. The staff also are now required to know about intoxication signals. So if we haven't done staff training around that, we really need to do that. And I have a little tip slide that's included here for you on elements you might want to address. And then if the facility determines that there are illegal substances, they're supposed to contact law enforcement and not act as law enforcement themselves, which I think our staff would be greatly relieved by if they can get law enforcement to respond. Common missteps for you all as providers. First off, we're seeing a lot of nurses simply order a drug test, and providers are brought in complicit to the situation. And essentially this is considered an unlawful search as well. So you cannot order a drug test for a resident unless they ask for it or consent to it. And so if you suspect their resident is going to overdose, is actively intoxicated, the CMS guidance is for us to utilize Narcan and to have it readily available. If you have not yet made that readily available within your community, you really do need to institute a policy and procedure around that with your quality assurance team. Make it available to non-clinicians as well for administration in emergency situations, and make sure everyone is trained in the ability to administer it. A lot of folks think that they're going to hurt somebody by administering Narcan naloxone in error. It actually cannot cause harm. So it is something that a non-clinician can administer. Bottom line with this whole situation is that residents are making a choice to actively use substances, and it's their choice to not do that as well. So you have to collaborate with them on development of a care plan. Sometimes this is a very, very difficult situation. You have to educate them on risks and benefits. Your desire, of course, is not to have a drug-to-drug interaction or be held liable for something that they might administer on their own. So you have to have some sort of safeguards in place with your care plan and determine when an ED visit is appropriate, what the resident is willing to do in terms of their own compliance with a drug regimen, treatment regimen. And they oftentimes will have to be offered an A or B choice. Do you want the prescribed medication, or do you want to continue to use? And then you have to train your nurses how to assess when to adequately hold that medication in absence of a drug test. So it's kind of like assessing for administration of other medications that need to have rule out of other clinical contraindications. So you have to look at each substance abuse possibility with its own unique properties. Like, are they typically going to use cocaine, for example, or something else? It's going to operate very differently than, say, marijuana use. So you cannot have an order that says to simply hold opiates because you suspect that they're using drugs. You can't withhold their medication based on a suspicion, nor based on a drug test. So it really makes you rely on development of a collaborative care plan. We could go for a long time on discussing the ins and outs of this, but I wanted to give you a heads up to pique your curiosity if you haven't gone down this road with your residents. And we are required by CMS to identify people who are at risk for overdose. So this is my little advice cheat sheet based on the regulatory guidance. It's important to evaluate everybody upon admission and pre-admission and look at your current resident population so that you can have orders in place for Narcan administration if you want to direct that as part of the care plan. And here's a little quick review of the Narcan administration. This is not a training video on Narcan. It is something I thought would be of more interest to you all. The Narcan administration videos are like 2 minutes long on YouTube. There's 1,000 of them. Anybody can view those pretty easily, and I would recommend wide distribution of that training. But this training video here, Stat just linked to in an article today about opioid withdrawal and understanding particularly fentanyl, but what physiologically occurs, and then addressing some of the stigma around it as well. It's a 6-minute video. Here's the elements of training that I would recommend addressing with your staff. Because a lot of people think they understand drug use and they don't necessarily. We are all coming with our own biases. And there's a link here also for a Mayo Clinic overview of signs of intoxication by substance so that you can train specific to substances. And in terms of my other announcements, I'll quickly just review this. OIG released their final post-COVID report on nursing homes. It's good news, believe it or not. They affirmed that we did have significant staffing concerns, workforce concerns, that were exacerbated and made our management of COVID more difficult. They are recognizing that we have continued residual impact to our profession for costs, PPE compliance, workforce development, and all of that as a result of what we were experienced in COVID. And then they made recommendations to CMS that are actually quite supportive of our improvement from our present position, including reassessing nurse aid training and certification requirements, which has been a significant barrier and is up for legislation at the federal level currently. And if you were not aware of this, another training that you will want your staff to have direct access to, it's a 30-minute quick learning from Telegen and others. I helped instruct for this on appropriate use of the MOST form and inappropriate use, and our regulatory requirements for advanced care planning period are covered by me in this exclusive of the MOST form. That's part of it, but it's not the whole schmear. There is a component here that we need to address, that it's always voluntary and intended specifically for patients who are at risk of a life-threatening clinical event because they have a serious life-limiting medical condition. It is not to be used blanket for absolutely every admission. And then this is our upcoming events, including dementia care training on Friday. If you have not yet engaged in that, you are welcome to join us. And we have an assisted living conference coming up on April 4th. If you have a new nursing home administrator, our 3-day essentials course will be April 9th to 11th. I highly, highly recommend it. Dora endorses it. And we always invite people who are in AIT programs and training to become NHAs. We invite them directly by letter through Dora. And then we have a wound conference coming on April 10th as well. So we hope to see you all there. Thank you.
Thanks, Jenny. That was excellent. There is one question from the audience, and where did that go? The question from the audience: can an RN And LPN withhold PRNs if the patient is intoxicated.
As long as you provide assessment criteria under which you want that done, yes. You have to educate your nurse as to what they're actually looking for, and I would include it explicitly in your orders.
Okay. Great. Thank you very much. Our next presenter, our important partner with Health Department is Chad Fear. If he is on.
Hi, y'all. Was working through some technical issues earlier. We had our roundtable meeting, and some of the information that I have to share is what we discussed at that meeting. So for some, it might be a recap, but I did want to let you know that we've done some trending with immediate jeopardy situations in the last couple months, and we've seen immediate jeopardy with elopement, suicide attempt, choking risks related to food textures. And we've had a couple situations. One was an immediate jeopardy situation, and the other, it ended up being resolved, but it had to do with a malfunctioning dish machine. And this was a situation where it was intended to be a high temperature machine, stopped working at high temperatures, was converted to a low temperature machine using chemical sanitization, and it wasn't being monitored, malfunctioned, and we're not really sure how long, but it looked like it was an extensive period of time that the tableware, drinkware, cookware were not sufficiently being sanitized, placing residents at risk of foodborne pathogen. So that became an immediate jeopardy situation. Did some trending too for the tags that are being cited, and you will really not see any changes from previous reports that I've done for either this group or previous reports to the community. NHSN reporting has been at the top of the list for months upon months and well over a year. And this is a CMS direct site. When the reporting requirements aren't met. This is a tag, though, that often is IDR'd and is overturned. So facilities are able to provide evidence of that report. And then the tag is dropped. These next ones are consistent across Colorado and the nation in the same order: infection prevention, freedom from accident hazards, and sanitary food service. You know, those three areas in and of themselves consist of many different requirements. So to get a citation of noncompliance in those particular areas, there's a lot of ways to do it, I guess I should say. Freedom from abuse and neglect, respiratory care, pressure wounds, ADL care for dependent residents, quality of care, which oftentimes is non-pressure related skin conditions, professional standards, grievances, and environment. Here in Colorado, all survey types, so complaint surveys, recertification surveys, and revisits, there's an average of 1.7 citations per survey. On recertification surveys only, the average is 7.76, and these are very much in line with the numbers that we're seeing nationally. We did get some CMS clarification on informed consents for psychotropic medication. A previous question had to do with when one was required or not required. We received from CMS that you do not need to update informed consent with changes for a specific medication. A new informed consent is needed for each medication, even if it's in the same class as a medication that you have the informed consent for, and perhaps having the same same risks and results as the previous psychotropic medication. So that's to say that each medication needs its own informed consent, but within that informed consent, you do not necessarily need to update it for changes in that medication. Within that medication. Let's see. You know, and I guess one of the other things that came forward that certainly would involve medical directors and physicians attending residents in nursing homes, and that's with that discharge, getting those summaries completed as far as the resident's needs, particularly with facility initiated discharge. You know, what are the resident's needs? What has taken place at the facility to try to meet those needs, and where the needs cannot be met, leading to the facility initiated discharge. The one thing that I would point out is that when a resident is transferred to an acute care setting, the assessment of their needs has to happen when they're ready for discharge from that acute care setting and not from the nursing facility. So at the point that they're leaving the being transferred from the nursing facility, you're looking at somebody who perhaps has an exacerbated condition. In order to be an appropriate discharge from the facility, the resident has to be assessed after they've been stabilized. And then it's determined that even with stabilization, the facility is unable to meet their needs. Folks, I think that's all I have for you today, unless there's any questions.
Hi, Chad. I think there are a couple questions from Dr. Reddy, and I'll in the chat, and I'll read them. And if I miss it, then I'll ask Dr. Reddy to unmute. But the first is, when a resident is exhibiting signs of SI without means or ability, what are items that CDPHE looks for to ensure the facility is staying in compliance?
Okay.
So
when
the
you
further, go ahead.
Oh, I was just asking about the acronym SI.
Oh, suicide. I assume it's
Okay.
suicide ideation.
So what we would be looking for in that situation is, how are they dealing with the person's psychosocial, emotional condition? That, you know, if they're able to work with the person, the reasons why they may be suicidal, what's contributing to that, and if the needs of that resident are beyond the ability of the facility to address that emotional status, that the facility is looking outside of its resources to provide that resident some support.
Okay, and the follow-up question to that or comment was, some facilities do one-on-one and some do 15-minute checks, but it's questionable whether 15-minute checks were acceptable. So I'm not sure if you guys parcel out that level of detail or.
We do not. We do not direct care. What we would do is to assess whether the supports and resources that the facility has determined that the resident needs, if our assessment would be is if it's indeed meeting the person's needs, keeping them safe. Is because sometimes even a one-to-one is not sufficient to address particular needs.
Great. And the last question is, do changes in medications also include increase in dose for informed consent? That may be for Jenny or either of you.
So we dealt with that a little bit with our question with the psych meds and the informed consent question we had for CMS. And the information we got back was they would not expect a new informed consent for dose increases or decreases. And the caveat that I added to that was, unless an increase in the medication dramatically impacted the potential that a person may experience those side effects, or that the side effects may worsen because of the risk is going to be increased, then you may want to consider addressing that. But within the parameters of that medication, changes in dosage would not require an informed consent update to the informed consent.
Okay, great. Thank you very much. We're very excited. I think this is a first-time presentation, dental care in the nursing home, and I'm going to open up to have Dr. David Shepard introduce our next speaker.
Yeah, excellent. If we can get our slides up too. Yeah, it's my pleasure to introduce Dr. Melissa Musolf. And she's a dentist with a DDS degree from Marquette School of Dentistry. She practiced in a level 1 trauma center in Fresno, California for a couple of years after dental school, then moved to corporate dentistry and had her own practice for several years as well. She retired, I put that in quotes, in 2021. And since that time, she's worked with Visiting Ancillary Services, which is a nonprofit organization that provides services to long-term care and other areas as well. She's going to talk to us today about dental care in the nursing home, particularly looking at antibiotic prophylaxis and antibiotics, as well as anticoagulant management as it pertains to dentistry. So with that, I will hand the screen over to Dr. Musolf.
I'm going to ask her to unmute.
Yeah, are you there, Melissa? You may be muted.
Got it now?
Yes.
You got it.
Great. Truly an honor to be invited. I'm not a public speaker, so I don't really enjoy any of this. I like being in people's mouths. So bear with me as I go through all of this. David, again, thank you for the invite. Today we want to go through this kind of quickly. There's about 20 slides and I want to be able to answer questions. And if I don't have the answers, I'd be happy to find them out for you all and get them back to David so that we have a good knowledge and consensus of what we're talking about here. We want to talk about the antibiotic prophylaxis, which is what you guys were kind of hinting on, anticoagulant and antibiotics. If you go to slide 2, and I'm going to go kind of fast, these are the 4 things that as a dentist we're looking for. Number 1 and number 3 kind of go hand in hand because, again, we're talking about a heart disease that has either been repaired with a patch or a device that is not per se natural. And so we head back to the number 1 position, which is you should use a prophylactics. So anyway, and then a previous endocarditis infection, and then transplant recipients, heart, but also lung. There's also other transplants, but we don't want to touch anyone for 6 months anyway, after any type of a surgery. But the ones that we do a pre-med for, that's how we call it in dentistry, pre-med for is going to be heart and lung for the rest of their lives. The others, which are like kidney, it's just a 6-month thing and then we don't do anymore. All of this, though, is dependent on whether or not they have problems after the surgery, right? Obviously, if you have a transplant that didn't take well, then you're going to want to do a pre-med. But these are things that we have to talk to you MDs about because we wouldn't know that information. Again, reading some of the medical histories, not everything is real clear in a dentist's mind of what does that mean or what does that acronym mean, stuff like that. So it's really, they always want us to consult with the medical people to find out, the medical groups to find out, is there a problem with that? Yes, we have this, but is there a problem? Let's move on. Those are the 4. Refer back to that 4. These are the things that I think a lot of general dentists, unfortunately, do pre-meds for, but there's no need to. This is from the American Heart Association, American Dental Association, stents, prolapse, heart murmurs, joints. That was a change in about 2015, and then the pacemaker defibrillators. Again, there's always exceptions. If there's a problem with any of these surgeries, then we have to consult the physician, and then we may want a pre-med for them. These are the antibiotics we use. Most of the general dentists, we use oral antibiotics in private practice. And this again has changed. The American Dental Association kind of keeps refining things. We used to do it 2 hours before appointment. Now it's anywhere from 30 to 60 minutes. And then if we forgot, just give them a dose up to 2 hours after the procedure. It's a continuing change, and it's kind of interesting for me because I've been in practice so long that is even out there, but that's what they tell us to do. These are the types of the antibiotics: the amoxicillin, the penicillin, and the clindamycin. Although clindamycin, just as of recently, they do not really want us to use. I will tell you that it's a still go-to in dental infections, and we'll get to that here soon. Oral surgeons use the IV antibiotics. If you can't get a pill down your mouth in a general practice, well, it's probably something that you're not wanting to do anyway. And so oral surgeons would be taking out those teeth. Long-care nursing facilities, we probably have more of this issue where people can't take these orals. But again, you're only going to be utilizing these pre-medications for those very 4 specific type of issues, no other. So your quantity of patients isn't that great. Making sure you're reading the medical histories correctly. These are some tables. Again, this is going to be an oral surgeon table more than a general dentist. I don't do IV antibiotics. I never have. I never did, and I probably never will. I'll be handling that for you guys and having the nurse give that or whatever at the facility. I don't do that. Heading to some of the summaries and findings, you can see that even here, we're trying to clean people's mouths so that they don't have the risk of infection. There's more probables and possibles of a daily toothbrushing than there are if I come in and do a single cleaning. So we just want good habits. We want the nurses and CNAs and licensed nurse practitioners, everyone, to help minimize the amount of bacteria in the mouth by doing the dailies, but then having me come in and doing a more thorough, I guess, I don't know, job, since I'm a specialist in the mouth area. Here's some questions that were brought up. Antibiotics needed to dental cleanings. Again, go back to that chart. That's the only time when an antibiotic is needed for dental cleanings. So you have your heart valves, congenital valves replacements, and then you have your histories of endocarditis, and also, see, I'm even forgetting one. It's the cardiac transplants. Honestly, in general practice, we just don't see this type of history. So it's very minimum, but these are little signs that you can put up in our operatories that we can use to kind of, it's our little cheat sheet. But so going back then to some of the other questions, dental extractions, again, it would be those 4 main things. Let's see, obviously any of these mechanical or valve replacements, those are the ones that you do need to pre-med for. Definitely. Okay. Let's see, well, and then you go to the prosthetic joint. Here we go again. They're saying no, unless there was some type of a problem with the joint itself after the surgery. Then we would consult with you all, the MDs, to find out yes or no. Many times we've done it. The ADA had recently switched this, probably 2015, and that was when we were kind of on fence. Some were still doing, some weren't. The orthopedics were still doing, some weren't. We were having a hard time as dentists trying to figure out, well, are we supposed to or are we not supposed to? We then relied on the orthopedics. Well, some of them said yes, some of them said no. But really, if we are trying to follow the guidelines, it's a no unless there was a problem with the procedure itself. let's move on real quick here. This is from the ADA. We're not supposed to be taking people off of anything, anticoagulants or antiplatelets, all of them. We're not supposed to be doing that. We want to try to control this by localized measures. So the tea bags is because it has the chemical in it that helps clotting. The gel foam it's an interesting material, but you put it up into the socket after a tooth has been pulled, and it really does a great job of forming the clot. And it's a clot, not a scab, but we are not supposed to be removing anyone from any of this stuff. Now, that's general practice. Here we go. If we're talking about an oral surgeon who's going to edentulate the entire arch, plus do some bone manipulation for, let's say, preparing it for a denture, they're going to pre-med a lot more people, and they're going to take them off of these anticoagulants or antiplatelet items. General dentists, no. And for the things that we're going into the nursing homes to do, no. Local measures. So next one is, when do we stop? We shouldn't. We shouldn't. Dental extractions, we shouldn't. I would say I feel comfortable extracting anywhere from 3 to 4 whole teeth at a time. A lot of these patients that I see are little root tips. They're not even in the bone anymore. They're held in by the periodontal tissue, probably buried. It's easy to do a suture and have them bite down on a tea bag and they're clotted. So oozing is not active bleeding. We got to try to remember that. Oozing is where you're still having a little bit of blood through the mucus of the mouth, or they go to sleep and they still have a little bit of pink on the pillow. That's not active bleeding. I haven't seen anyone with active bleeding where you can't get it controlled, honestly, ever. Localized measures are fine. Let's talk about the different types of infections. You have tooth originating and gum tissue originating. If you guys do an antibiotic because you see a swelling in a gum and you don't know it's from a tooth or a gum, and you give one type of an antibiotic, it's probably going to work just fine until someone gets there. We'll talk about that a little bit more, the different types, but one originates from the tooth and the other originates in the gum. The antibiotics, we typically use are penicillins, amoxicillins. I might have been skipping here. We got a couple little stages of caries development. That would be a odontogenic problem. So you're going to have a cavity that starts and then gets into the nerve of the tooth. That bacteria then goes down in, and that's going to be something that can either form an abscess. It would be lower in the jaw. It can form a cellulitis. It can form a fistula tract that looks like a draining pimple. Gum infections are typically a puffy area right on the top by the crown of the tooth. So it's more on the top, different spot because it's a different type of infection. Let's see, can we treat dental caries with antibiotics alone? Unfortunately, no. A dental cavity is in a hard tissue. It has to be removed. Antibiotic won't treat a cavity at all. Fluoride, stannous fluoride can help slow it. The bacteria doesn't like it. You can apply it to the cavity, but the cavity is still there. To the dentist, Augmentin. That's a hard-hitting antibiotic. I probably wouldn't do Augmentin as the first choice. Because again, we don't know what's causing the pain. So everyone likes to treat a symptom, that's pain. Okay, what's causing the pain? Is it an abscess? Augmentin would be awesome for that. but cavities are the things that produces the throbbing of the nerve, and you can't treat that with an antibiotic. Antibiotics are for infections, but it's more of a soft tissue infection, not dental decay, although it's infection of the dentin. There's no blood supply up to that area to treat the dental caries. That's why we still have rapid decay still. A lot of this was from the American Heart Association, Medical Association, and Dental Association. There's some other studies that were included in this, but I wanted to kind of get through this fast so that, please, if there's any questions, and I'm not able to like scroll to see them. So if you wanted to unmute yourself and ask any questions, absolutely. The Corta antibiotics, which I don't see was in there anymore, we do a penicillin 500 TID for 7 days, or amoxicillin 500 TID. If it's a hard-hitting, like with a sinus infection, that's when we go to our Augmentin, 7 to 10 days BID. Periodontal, amoxicillin is like the best. If it's something, again, you need a hard hit, we had to clindamycin, and that's a 7 TID of 500, 7 days. So, but again, a lot of people are treating pain, throwing them an antibiotic for pain, unless they have swelling, will not help the pain. We're using Tylenol and ibuprofen. Of course, in the setting that we're in, Tylenol has to be, guarded with liver issues. So, and ibuprofen with the kidney issues. But we as dentists have tried to get away from the narcotics. Plus, in the long-term facility, I can't really, it's hard for me to prescribe it there. I'm always having to call the RN or get a hold of a medical director. So I just try not to do it at all.
So I have a question, if you have a minute. So
Oh, yeah.
it's not uncommon for us to have trouble to kind of get a dentist to come in, but we have somebody with an obvious dental carie. They maybe have a little swelling and they have some throbbing tenderness. And, we all think about, if it's going to take 2 weeks to get this person in, should we give them an antibiotic? Are we really helping, or is it more the procedure that you guys do that's going to take care of the problem? Is the antibiotic needed in the case like that?
If there's true swelling, so in that periodontal area right around the crown of the tooth, if there's true swelling there, or if there's true swelling down deeper in the jaw, or like a palpable, almost a cellulitis, then the antibiotic will work. Yes. A throbbing tooth, not necessarily. A throbbing tooth is dental caries that have gotten, if you see that slide, the dental caries have gotten almost to that nerve area in the tooth, and that's what's making it throb. So it's hard to, antibiotics is hard to treat what we call a reversible or irreversible pulpitis, because it's not really an infection per se until it's down into the tissue where it's an infection. Removing the tooth or the dental decay is really what, or doing a root canal is what helps that situation. If you see a swelling, yes, antibiotic. If you see a dental cavity, not necessarily.
Okay. And so pain therapy would probably be kind of the mainstay to start with. In either like an NSAID or a Tylenol would be, I'm guessing the
Yes.
NSAIDs are probably pretty effective for this if you can use them.
Yes, so what we're doing as far as for pain control is a 500 milligrams of Tylenol with a 400 ibuprofen. That works better than most of the narcotics out there, actually. And then we're doing it about every 6 hours. But if they can't take one, then yes, you're going to have to manage them a different way. And you're all more familiar with the opioids than I am, actually, or the other NSAIDs that are, I guess, prescription, or tramadols or whatever.
Okay.
Mm-hmm.
All right. Any other questions?
Thank you. There is a question in the chat box from Dr. Pallett, and sounds like I should be asking how many teeth are being extracted And what kind of local anti-bleeding measures are being used? Any other questions before considering stopping blood thinners?
That's perfect. And I think the people that are coming in, you know, they may have a different philosophy than we, or they may not be following the American Dental Association's guidelines in regards to these blood thinners. But yes, how many teeth is important. And remember, root tips versus an actual tooth is different scenario also. Root tips that are just basically their teeth that decayed, and now they're little nubs, and they may be covered by gingiva so you don't even see them. But those we typically take a 15 blade, we open it up and we plop them out. Well, that's a very easy extraction. However, you just cut your gum tissue. Okay, you throw your suture in. If it's not very big, you don't have to throw the suture in. So the more teeth, the more bleeding. Bigger root tips or the actual tooth that needs to be pulled will produce more bleeding, because now you have bone and gum tissue that will bleed. But again, localized measures with the dentist, gauze pressure, tea bags, and gel foam should be used.
So would you say
Right.
that 3 to 4 teeth is kind of the standard cutoff
Yes.
for a lot of dentists? Okay.
Great, Dr. Musolf, thank you so much. It was very helpful. I really appreciate the concise slides. These will, of course, be available on our website. I wanted to.
Thanks, David. Mhm.
Sure. Thanks for coming.
So the last part of our program this afternoon, we will want to discuss our annual conference. And I want to remind everyone this, you know where we are virtually on Zoom. This is where we are on the web, cmda.us, and a couple of helpful locations here, meeting archives. You can locate the past meetings, any attachments or any attachments are provided here, and also the Geriatric Journal Club lives here. But we wanted to give a few minutes to really highlight our excellent annual conference. And so we've got the schedule here. I've got a couple of people, board members want to highlight some things. And so I'm going to ask Alicia to talk about a couple of presenters at our annual conference. If she is on.
Hi, Chris, can you skip me for just 1 second?
Yeah, absolutely.
Okay, sorry.
So how about Leslie, Dr. Leslie Eber?
Great. Thank you so much, Chris. So I'm going to be talking to you first about one of the presentations that I'm really over the moon about. Dr. Nashira Padma, I'm not sure, I hope I'm correctly pronouncing her last name. She's really the leading national expert on managing diabetes in post-acute and long-term care. And that's really what I want to know. There are a lot of new medications out there, and I want to know how to correctly use them. And she's written multiple articles on the management of diabetes, how it has changed, and what we should be doing now. One of her latest articles was in Caring for the Ages in January. I think it was January, and it's a game changer. So please consider coming for her diabetes presentation. And then the other presentation that I'm really jazzed about is Dr. Ott. She's going to be talking about deprescribing, and we've heard her present nationally. And what I really love about her presentation is she presents really some real world scenarios. What does the patient family say? You should not stop my mom off that Aricept. It is saving her life and preventing her dementia. Of course, we know that that's not true, but it talks about how to navigate those real world conversations and how to, what she says, deprescribing, which I really appreciate. I'm also filling in for Allison because her audio is just a little bit wonky today. And she's going to be introducing our keynote speaker, Diane Sanders Cepeda. She is, she brought the house down last year with a standing ovation. She really talks about diversity, equity, and inclusion and culture change. And she really does this masterfully. If there's one person you really want to see, it is Diane.
And then, of course, Carrie Levy will be presenting. She's really an international expert on geriatrics, but she's going to unpack all of those new anti-Alzheimer's medications. What does it really mean for us? What we should be saying to patients, and how can we unpack the data so it's meaningful for us? So those are the presentations that I'm over the moon about. I hope to see you all on April 19th at our conference. Thanks, Chris.
Thank you. Thank you very much. I'm going to ask if I have my favorite, and I'm going to ask if Dr. Rebecca Jackson is on to discuss another great presentation at our annual conference.
Yes, I'm here. Can you hear me okay?
Yes.
Okay, great. I am really excited because Elizabeth Ekstrom is coming out to do a presentation on Tai Chi for us. I met Elizabeth during my fellowship out in Portland. She is the geriatrician in charge of their geriatric practice there at OHSU. She does a ton of teaching with medical students and the fellows there. And she just is an amazing human being and a wonderful teacher, but her area of interest is Tai Chi and how it relates to fall prevention. She was recently featured in an NPR article, and I can drop that into the chat. And she's going to come out and talk to us about the benefits of Tai Chi, not only for falls, but for cognition and how we can work to implement it in long-term care. So make it very applicable to our day-to-day work. So I'm very excited to have Elizabeth come and present to CMDA.
Thank you. I'm going to ask if Sing can talk about some presentations. Dr. Pallett.
Yeah, I'm really excited. I feel like this annual conference also showcases some of the really wonderful benefits of being part of CMDA. We have community partners that for years have been building and strengthening this relationship with CMDA, which tells me that their organizations find medical providers' voices important in their work too. Jenny Albertson, who gave us our first presentation today, is going to be talking about the CHCA trends in the LTC profession. So thank you very much, Jenny, for joining our annual conference. We also have Dr. Chris Chaya and Elaine McManus. No, I'm looking at Elaine, but thinking Joe Tanzi, because we have the CDPHE represented at our conference also. This is just huge. There are many state chapter AMDA conferences that happen without any public health department involvement. And here we have two wonderful speakers, Joe and Dr. Chaya, coming to speak with us. We'll have an update from the CDPHE and talk about strategies to prevent antimicrobial resistance. And then in the middle of the afternoon, another community partner will be represented, which is Telegen, and that's our quality improvement organization. And Dr. Christine LaRocca is going to be presenting on an update about what Telegen can do for our communities. So really excited, and I also hope to see you on April 19th.
Great. Thank you, Dr. Pallett. And the last, one of the last introductions will be from Alicia to talk about another presentation at our annual conference.
Hello, can you hear me now?
Yes.
Okay. I'm going to introduce you all to a colleague and a friend of mine, Samantha Conley. She's a speech therapist, and she's going to be giving us a talk this year. We usually like to have at least one therapist come and educate us. And so this year we're going to have her come, and she's going to be talking about how speech therapists can help us all manage our patients. In her experience, speech therapists are generally underutilized, and she would like to help us understand how they can, be involved. And she will talk about dysphagia. She'll talk about how to make diet texture decisions, and specifically at end of life or patients on hospice. She'll touch on that. She also is going to touch on cognition and how speech therapists can help us with our dementia patients, helping us with safe discharges, all those things. She's a proponent of maintaining quality communication channels with all providers. And that's because it tends to lead to better outcomes for the patients. So that will be her main take-home message. And she is very knowledgeable, and I think you will love her.
Thank you, Alicia. I would also just like to point out, after a year or two of absence, we have our own very esteemed Dr. Greg Gom will bring back the post-pandemic Kentucky Derby, which is always a popular event. And again, reminder, you can go to our website here at home and the annual conference, and then registration is easy to click here and you can register. So please remind all of your facilities and everyone that this is a really important way to connect with our colleagues and kind of recap everything we've learned this year and learn a lot of new information. I don't know, we might be giving people back some time of their day unless we have other questions or comments.
Can I make a further announcement? Because
Please.
we're in announcement mode here. And we were just talking about the Colorado CMDA conference on April 19th, which, as Chris mentioned, you can sign up today. Just go to the website, hit register. If you sign up before April 8th, you will get an early bird discount too. But this weekend, there's another conference that involves many people here at CMDA, and it's the National Conference for Post-Acute Long-Term Care Society at AMDA. It's in San Antonio. It starts this Friday, runs through Tuesday. If you have not made plans to go to Texas yet, it's still not too late. You could go, or you could also sign up and join virtually. There's a virtual learning track, and you can get CME and be part of the fun. Now, one of the pieces of this conference, which to me is like the most important part and is not virtual at all, is actually our Colorado reception at this conference. It'll be Sunday evening at 6 o'clock. Leslie and Rebecca found this really great restaurant that's just right outside of the convention center. And we're combining forces with the Mountain West chapter to have this amazing reception where you can come and have some free tacos, empanadas, quesadillas. And I think, Leslie, you signed us up for beer and margaritas too, right?
Yeah, it's so worthwhile to come. You can have dinner on us, and you can have a multitude of beverages as well. You actually can choose from their signature margaritas, and then they have sangria and beer and lots of other fun things. But mostly it's the people, of course, that it's great to see your colleagues and have a lovely dinner. So we hope to see you there.
I'm really looking forward to that. And finally, I just want to congratulate all these people from Colorado who will be presenting at the conference. I know that you're getting your slides ready and practicing and getting your tickets and find out what to wear. And this will be a really great place to showcase some of the expertise right here from Colorado on a national stage. And then finally, another congratulations is in order. The nomination this year for the future vice president of AMDA only has 2 people on the slate. And one of them is right here from Colorado. And she's the one who just told us about the margaritas and sangria and beer, Dr. Leslie Eber. Well, good luck to you, Leslie, as you run for vice president of AMDA.
Thank you.
Congratulations. Okay.
These are the announcements that I have.
All right.
Chris.
Anything else?
Yeah, Chris, one quick announcement. This Thursday at 12:31, we're going to have our monthly geriatric journal club, but Singh and a couple other docs are going to be presenting on PCR testing of urine, which I think a lot of clinicians have a pretty good idea that this is not a terribly useful test, but there are a lot of administrative people that think that marketing is more important, and a lot of facilities are starting to use it. So I would just encourage as many people as possible to be on that call so you can talk to your facilities and try to practice good medicine as a result. And if you don't have if you didn't get an invitation from me, get in touch with anybody here. They'll forward theirs, or I can send it to you.
The last, I would also like to just point out the same first Thursday of the month at 8 a.m. is the monthly ethics committee meeting. And I highly encourage everyone to attend that. Since I've been attending, it's made me think of actually a couple of cases to present. So it's a very worthwhile discussion.
Thank you all
All right.
so much.
And
for
I'll be
joining
glad.
us today.
Yeah, and I can send the invitation out for that as well. It's also attached to the Journal Club invitation.
Two separate links. Yeah.
Great.